Next speaker is me. I'm going to be talking about the role of interventional cardiology and pre and post-stage palliation. I have to say I'm going to focus a little bit on hypoplastic left heart syndrome in this talk. Just the role of cath at the different timings, starting from prenatal on. These disclosures are not particularly relevant to this presentation. So I'm going to cover the different stages before surgical palliation, postoperative and interstage, the beginning, and some recent innovations and some case examples and conclusions. Starting with very early, we have to cover a little bit of the role of interventional cardiology in prenatal univentricular heart, especially interventions which are rarely performed in some centers and more in others, such as creation and dilation or stenting the atrial septum in hypoplastic left heart syndrome with intact atrial septum on aortic valve balloon valvotomy. Focusing first on the intact atrial septum in hypoplastic left heart and fetal diagnosis, the group in Boston in 2004 demonstrated the initial experience with that in a few patients in whom through a needle where we're able to transverse the atrial septum, and then you can deliver put a coronary balloon through that 19-gauge needle and then open the atrial septum as being successful. Still, however, of those 7 patients, 4 of them ended up dying. So, obviously this is a really bad condition with very poor prognosis. So these interventions may or not really change the outcome of these patients. In this other publication, very beautiful illustration of the impact of that high left atrial pressure in fetal life. We know there's many contributions by others that also show how those high pressures in the pulmonary veins can have significant impact on the development of the lungs and the pulmonary veins in these patients. And in this group, you can see the delivery of a stent, and that can be delivered through an 18-gauge needle directly in the atrial septum, and then lower the pressure in the left atrium. So it's clearly feasible, but these patients clearly have very poor prognosis. Fetal aortic valvuloplasty, that's a procedure that particularly pioneered by several, but especially the technique has been perfected by the group in Boston. We know that some fetuses with aortic valve stenosis present at mid-gestation with a dilated left ventricle and arrest growth, and that, the idea of fetal intervention is to prevent the development of hypoplastic left heart syndrome. And there have been specific parameters that help you identify who these patients, these fetuses are. The technique includes an ultrasound guided, can be done percutaneous or laparoscopic, although most of the time it's percutaneous. The fetal position is key. And then through that 19-gauge needle, you can deliver a coronary balloon across the aortic valve, like is illustrated here, and open the valve that way. What are some of the data, what are the results of this fetal intervention that we know? So this is actually a meta-analysis of a large number of studies that had at least a significant number of fetal valvuloplasties performed, and the total was 389. This is published recently. There was really high rates of technical success that you can see over here at 84%. However, a fetal mortality of 20% and a successful biventricular circulation achieved give you an idea of about a third of the patients, ranging, you can see in some up to close to 40% on some centers. I think that's Boston. And then potentially postnatal univentricular circulation, another third. So it gives you an idea of this intervention can possibly lead to a biventricular circulation in a third of those fetuses. Now, I think we have to recognize that when you look at the data from the Boston group, that these biventricular outcome patients are not really perfect biventricular patients, okay? So the insult to that left ventricle, that's not gonna be a normal left ventricle in most of those patients. You can see here the significant number of interventions that these babies may have had. So these are the biventricular babies from birth. And you can see, especially when you look at 39% of neonatal Ross procedures. Okay, well, that's a significant surgery. Mitral valve replacement, 16%, aortic valve replacement. And in the ones that were converted to a biventricular, so they did not start, but they were rehabilitated over time, there's a significant number of babies that end up having procedures such as 86% EFE resection, mitral valve repair, mitral valve replacement, 43%. We all know that toddlers with mitral valve replacement are really extremely difficult to manage. So I think it's so important. This is not just a matter of ballooning an aortic valve, it's a complete program to rehabilitate the left ventricle. And for that 1/3 of patients that may actually achieve biventricular repair, you have to understand that the commitment for ongoing rehabilitation has to be there. And it would be wonderful if we could identify what are the predictors for a successful biventricular repair that does not require mitral valve replacement and that ends up with a healthy left ventricle. Because the issue is that there's a big price that all those other babies are paying because they end up in a situation where it's pretty suboptimal in terms of their physiology, and sometimes not even being able to be candidates for transplantation because of the chronic left atrial hypertension and pulmonary hypertension secondary to that. So the story still needs to be told, I think, about should we all be doing this or not. Now, after birth, what do we do after birth? Well, prior to stage 1, clearly one of the interventions that we perform in these patients that sometimes can be emergent is the left atrial decompression in babies that have restrictive atrial communication. So especially in the hypoplastic left heart syndrome with complex with mitral atresia or mitral stenosis and restrictive atrial communication, it's rare to have to do emergent atrial septostomies in patients that have right heart obstructive lesions. Obviously, because of the PFO anatomy, the higher right atrial pressure tends to keep it open, so it's rare. But sometimes we do have to do a septostomy in a pulmonary atresia, intact septum, or a tricuspid atresia, but they tend to be rare. And all of these techniques include the traditional septostomy, static balloon dilation. Sometimes with intact septum, we have to create a transseptal puncture, sometimes in collaboration with a CTO wire or placing a stent or radiofrequency assisted perforation. So, it always comes the issue when you have to do a septostomy in these babies, can you do it at bedside in the ICU? Clearly, if you have a thin atrial septum with a PFO and you have an umbilical line that enters the heart, it should be preferred to do in a cardiac ICU on the bedside. Now, for these babies with hypoplastic left heart structures, that is typically not the case. So no, this should be done in the cath lab. You need all the help possible. Sometimes you may even need TE guidance. And so it's very, very important to have all the views and all the tools you may need and to be in the cath lab for that. Sometimes this is done emergently as the baby is born, gets immediately transported to the cath lab. Sometimes they're semi-emergent, there's some restriction and it tends to progress over time, and then we decide to go to the cath lab because of progressive pulmonary edema and a higher gradient that's documented on the echo. This actually is one of Diane Spicer's heart specimens, but you can see that the anatomy of the left atrial septum in these babies, and this is in this echocardiogram, can be pretty tricky. In this case, it's intact, but in here, you can see that there is an opening, and it's not uncommon that you have a posterior deviation of septum secundum here, and so it's like a tunnel. So the tricky thing is to get the septostomy balloon on the other side of this tunnel, and that can be sometimes extremely difficult. This is the baby we had this week, emergency transport to the cath lab after birth. and had a gradient of over 20 across the PFO, and had this tunnel, this double, so septum primum here, septum secundum here, and you can see that here we were in the middle of the tunnel. This is a lateral projection, a wire was across, did balloon dilation and didn't do anything because the flap was still occluding. You can see a left atrial injection here with a pulmonary vein filling. Finally, we were able to get the septostomy balloon to the other side of this membrane, and we were able to do the septostomy, which really succeeded in tearing that thin second membrane that there was in the atrial septum. You can see when the left atrial pressure went from 20 to 7, how much smaller that left atrium became. So this left atrium appears good size, but it is because it's distended and hypertensive at high pressure. So sometimes we have to do transeptal puncture in an intact atrial septum, and those are really tricky, especially if the left atrium is really small, as some of these babies may have. And there are occasions when you just have, if it's very thick, the best option maybe just go directly and do a surgical septectomy because of the difficulties that we may have in the cath lab, open an intact septum with a tiny little left atrium on the other side. So then, as a cath doc, we have to talk about the hybrid procedure because obviously that typically involves stenting of the PDA. So this is really a combination of the CT surgery and interventional cardiology working together. The key things for a hybrid procedure is providing an unobstructed systemic output through a PDA ductal stent and restrictive atrial communication, which is often done with either septostomy balloon or atrial septal stent, and then protecting the pulmonary bed with typically bilateral pulmonary artery bands. As these ducts are large, the stents that are used are self-expanding stents, as opposed to balloon expandable stents that we reserve those for the very much smaller. And if you have a preemie, you may be able to use those. The ductal stent is implanted directly through the main pulmonary artery as introduced by the group in Nationwide. And most patients are candidate for a hybrid procedure, but there are some anatomies of PDAs. And when you have this retrograde obstruction with the 3 sign that Mark Busek many years ago described in Colorado, these patients are not good candidates because you stent the duct, you occlude the retrograde, you can cause retrograde aortic coronary stenosis, aortic obstruction. So those patients may not be candidates. So that's important to look at the PDA anatomy. Now, most recently, we have been able to avoid the use of pulmonary artery banding, and some of these babies can have a complete percutaneous procedure where flow restrictors, this is the modified Medtronic microvascular plug. This was introduced published in 2021 by Shan Sathanandam and Not Craig in the group in Le Bonheur. You can cut little holes in the microvascular plug and then deliver those at the branch PAs, and that restricts the flow. One of the problems with these is that they can move forward, move distally, and sometimes they're tricky to retrieve. This is another publication showing how in Europe they're retrieved using a snare intraoperatively to try to get them out because they go distally, and so the surgeon doesn't have to dissect the pulmonary artery to get them out. But so they're a little tricky, but that offers a new option for some of these babies that we do not want to necessarily open the chest and deliver these in the cath lab. They can be done through a 4 French catheter. In our experience, we started doing hybrid procedures in 2009. John mentioned a little bit of that. We had looked back at our data, and the low-risk Norwood babies had a mortality of about 80%, while the high risk had 25%. And the risks of these patients, this is before 2009, these were the risk factors that really, those babies had a worse outcome. So from then on, we started doing hybrids on all these high-risk babies, and then compare the results of hybrids to high-risk Norwoods. And in this initial study that we published in 2018, there was not a real survival benefit of a hybrid procedure for all these patients at 1 and 5 years. However, for some risk factor, this was. So if you had a premature infant, that was a significant survival benefit of using the hybrid procedure in our experience. And of course, hybrid procedures have been used throughout the world. In this analysis from the Congenital Heart Surgeons Society on the critical left heart obstructive lesions, this is published quite recently, there were 214 hybrids and 831 non-hybrids, and they were compared. And in this series, there was no significant survival benefit, even when they were looking at weight. I have to say, though, that, well, you know, whether you have a hybrid or you have, you know, an Norwood, if you have a high-risk driver, the outcome may not be very good, okay? So the issue is that you have to realize that there's a few things in these studies or results of the hybrids. First, there were patients that didn't make it to any surgical series that were not offered anything because they were not candidates for a Norwood, and now we're offered a hybrid. So it's when you're comparing the two, you're not being very fair because those patients would not have been offered anything. And there are some some patients that are not even candidates for a hybrid. I mean, they would be death versus hybrid. So those are the options, right? Because maybe they have a brain bleed or some issues that can't really go for a Norwood. And the other thing is that not all risk factors are the same. And so there are some risk factors, such as if you have multiple congenital anomalies, that's not going to go away when you come back for a Norwood 2 months later, okay? You're still going to be high risk. So, and there are some risk factors that are transient. If you have, it could be that you have decreased ventricular function because of a traumatic delivery or something like that, that gets better. You can get them through a hybrid and maybe they recover and they'll be a relatively good risk Norwood if they recover. So there are risk factors that can change and others that persist. So I think that that's the truth. And the other thing is a lot of the use of the hybrid, there's a very significant patient heterogeneity. So hybrids is also used for staging biventricular circulation or in borderline left hearts. And those patients don't end up going for Norwood, end up going for biventricular repair. So we have to recognize that that makes the data pretty dirty when you're looking at some of these publications, is because patients are not all the same. What do we do in this interstage monitoring after a hybrid? It's similar that we do after Norwood. Cardiology assessments every 1 to 2 weeks. We check for PDA restrictions, retrograde aortic flow. We check for the atrial septum. It can develop restriction. Any signs of decreasing function, of increasing tricuspid regurgitation can be a sign that you need to come to the cath lab, especially if they're not doing well clinically, and they routinely would get cathed in preparation for the next step. Unfortunately, bilateral PM band sometimes causes trouble, and we see patients with pulmonary hypoplasia or pulmonary artery stenosis that can be difficult to treat. Sometimes we balloon those patients. Restriction, we obviously can do a septostomy. The other thing, PDAs, the stent sometimes moves a little distally and you can develop obstruction proximally. This happened to be a patient who was never a candidate for a Norwood and lived with a hybrid for 6 years. And then you can see the develops restriction and we had to restent. There's also retrograde obstruction here that can be ballooned and sometimes can be stented. So these can be managed in the cath lab, but sometimes when you see this is the timing to go ahead and do an Norwood. So you don't have to do anything because they are going to go for surgery. The group in Toronto, they reported years ago that if you had retrograde aortic obstruction, you can treat this with a reverse Blalock toxictoma shunt. So this is a shunt from the main pulmonary artery that will go into the innominate artery and will flow the opposite way and feed the coronaries. So that's a potential surgical solution to that. So before the Glenn, interventions that we get to do include interventions on the shunt, whether it's a Sanos or Blalock toxictoma shunt, coarctation dilation, embolization of collaterals, pulmonary artery interventions, atrial septoplasty, and of course, these babies are sick and they're having lines and can develop obstruction in the systemic venous pathways, and we often have to intervene in the cath lab and open them up. For interventions In the BTT shunt, sometimes you have to go through the neck, depending on the angle that we have. And we can flip the baby, and we do that also for the ductal stents when the access has to be carotid or axillary, to make it just easier for the operator. Sometimes you need to make it a little easier now. And Sano also can become obstructed, and these can be stented and treated in the cath lab when you have Sano obstruction. We know very well results are very good for coarctation intervention, and collaterals. These a mesh of collateral vessels are not rare in patients with single ventricle in the early stages, and we use a combination of particles and coils, mostly particles, to lower the collateral burden. We always look for potential decompressing collaterals in the pre-ligand cath. It is very important if you have a left SVC to a coronary sinus that you do document that the coronary sinus is not atretic, because that's a contraindication to doing any closure, of course, of that left SVC. Obviously that can be closed in the cath lab before or after the Glenn. We also, after the Glenn, would obviously be treating potential obstruction. It can happen with clot formation. There's different systems that we use in the cath lab to open up obstructed vessels by clot, including angiojet and the penumbra system, which is the one that we're using mostly lately. And this is an example of bilateral bidirectional Glenn with complete occlusion and how it is opened up. And we all know very well that a large knee aorta after Norwood reconstruction can end up obstructing the left pulmonary artery, and stent implantation is the procedure of choice for that, since a balloon alone would not do anything, since there is external compression. So in conclusion, we can say that cardiac catheterization plays a major role in the management of patients with univentricular heart in the early stages, and this role continues to evolve, as we've seen with some of the novel incorporation of new technologies, such as the flow restrictors, as well as the incorporation of the hybrid technologies. Thank you very much.